often talk about the body's fight or flight response. You hear a loud noise, your heart races.
Instantaneous.
Right, it's instantaneous. You touch a hot stove, your hand recoils before you even register the pain. We are wired to react to danger. Our bodies are essentially giant alarm systems designed to, well, to scream at us when something is wrong.
It is an elegant survival mechanism, really. Pain is information. Discomfort is a signal to change behavior, to stop doing what you're doing.
Exactly. I mean, if you break a bone, you know it immediately. There's no ambiguity. If you have a heart attack, you usually feel that crushing pressure.
Yeah.
But today we are looking at the complete opposite. We're looking at a system that is designed to suffer in absolute silence. It's a system so stoic, so incredibly resilient, that it can lose nearly half of its operating capacity before the central command center, your brain, even gets the memo.
It is the most deceptively quiet organ in the human body. And that silence, as you said, is exactly what makes it so dangerous.
We are talking about the kidneys. And specifically, we are diving deep into a very dense, very intense medical text, chapter 74, on chronic kidney disease. And I have to say, before we even get into the science, the thing that kept jumping out at me as I read this was the sheer deceptive nature of this disease. You can lose, what was it, 50% of your function?
You can lose nearly half of your kidney functions, sometimes even a bit more, and feel absolutely nothing. No pain, no change in how much you pee, not usually. You might feel a little tired, maybe a little sluggish, but in our modern world, who isn't tired? It's so easily dismissed.
That is terrifying. It's like driving a car where the engine is falling apart, but the check engine light has been cut. You just keep driving, thinking everything's fine, until you're stranded on the side of the highway.
That is a very apt analogy. The kidney is an organ of immense compensation. It has what we call functional reserve. It will literally kill itself trying to keep you feeling normal. The surviving parts work harder and harder. And that is why this deep dive is so important. We aren't just talking about kidney failure as some sudden event. We are talking about an insidious, systemic overhaul of your physiology that happens while you're busy making other plans.
So our mission today is to break that silence. We're going to decode the text, specifically focusing on this 3-month rule that defines the disease in the first place.
A really critical starting point.
Then we're going to walk through the factory floor of the kidney to understand why it fails. And there's some fascinating, slightly horrifying mechanics there. And then we're going to look at the domino effect, how a problem in the kidneys ends up dissolving your bones and starving your blood.
And crucially, how to stop it. Because unlike many organ failures where you are just managing the decline, with CKD we have a very specific set of levers we can pull if, and this is the big if, we catch it in time.
If we catch it. Let's start right there. The definition. The text was very specific about this, and I think a lot of people, myself included, assume kidney disease means your kidneys have stopped working. Full stop.
Right, like an on-off switch.
Yeah, but the definition in the source material is much more nuanced. It's not an event, it's a state of being.
It is. You have to look at the timeline. The clinical definition of chronic kidney disease, or CKD, hinges on 2 distinct variables, abnormality and duration. Specifically, you need to have abnormalities in kidney structure or function, and they must be present for 3 months or longer.
Okay, let's unpack that. Why 3 months? Why that specific number? Why not 2 or 6?
The 3-month mark is the clinical line in the sand. It's what helps us distinguish CKD from what we call acute kidney injury, or AKI.
Acute kidney injury, so temporary problem.
Exactly. Let's say you run a marathon in July and you get severely dehydrated. Your kidney function might tank for a week, that's an injury. Or let's say you take a huge dose of ibuprofen for a bad back and it affects your kidneys. That is acute.
It's a shock to the system.
A shock to the system, yes. It involves injury, but it is often reversible. The kidney tissue is incredibly resilient. It can bounce back from those kinds of insults.
So under 3 months, there is hope for a full recovery. The system can reboot, so to speak.
Generally, yes. The damage hasn't had time to become permanent. But if that damage persists for 90 days, that suggests the architecture of the organ has fundamentally changed. We aren't dealing with a temporary glitch anymore. We are dealing with a structural failure.
So scar tissue is formed.
Most likely, yes. Scar tissue has likely formed. And scar tissue does not filter blood. It's just inert. It's like replacing parts of the engine with concrete.
Okay, so time is the first variable. Second is abnormality. The text lists a few ways this shows up. And again, this was surprising to me because it's not just about not being able to pee.
Oh, far from it. In fact, most early CKD patients produce normal, sometimes even large volumes of urine. The abnormalities we look for are often microscopic. The biggest one, the one the text hammers home repeatedly, is albuminuria.
Albumin. Let's unpack that. That's a protein, right? It sounds familiar.
It is the most abundant protein in your blood plasma. Think of albumin like the gold bricks in the Federal Reserve. It is valuable. It is supposed to stay in the vault, your blood vessels, because it helps maintain pressure and keeps fluid from leaking out into your tissues.
Oh, okay.
The kidney's job, its main job, is to filter the blood, take out the trash, the urea, the toxins, but to be a very, very careful guard and keep the gold bricks inside.
So if we find gold bricks in the trash.
Exactly. If we find albumin in the urine, specifically more than 30 milligrams per day, we know the vault door is broken, the filter is leaky. Even if your kidney is technically filtering waste at a normal speed, if it is leaking protein, you have CKD. By definition, you have a structural defect.
That's a key distinction. You can have a fast kidney that is still a broken kidney.
Precisely. And this is where so many people get missed in early screening. They look at their creatinine levels, they look at the filtration rate, and it looks okay. It looks fine. But they ignore the simple urine test. The urine test is the early warning system. It's the silent alarm.
The text also mentioned other markers. Hematuria, what is that?
Hematuria is simply blood in the urine. Now, this can be caused by many things: kidney stones, infections, bladder issues. But if it persists for 3 months, and we've ruled other things out, it suggests the filter is damaged enough to let whole red blood cells slip through.
Which should never happen.
Should never happen. They're much too big to get through a healthy filter. You might also see electrolyte abnormalities, which suggests the tubules, the tiny pipes inside the kidney, aren't sorting salt and water correctly. That's a different kind of malfunction.
And there was one more structural abnormality that I found interesting because it seems so obvious, but it has to be stated.
Mm-hmm.
A history of kidney transplant.
Yes, this is an important point of classification. If you have received a transplant, by definition, you have chronic kidney disease.
Even if the new kidney is working perfectly.
Even if that new kidney is working perfectly. Because you have a fundamental structural abnormality that requires lifelong immunosuppression and management, you are never cured in the sense that you can walk away and forget about it. You are managed. You live with CKD.
Okay, so let's say we've established it. Okay, this person has CKD because they've had protein in their urine for 3 months. Now we have to figure out how bad it is. And the text introduces this framework called the CGA staging. It felt like a coordinate system for the disease.
It is exactly that. And this was a massive shift in nephrology over the last decade or so. The KDIGO guidelines, that stands for kidney disease, improving global outcomes, they moved away from just looking at one number.
Which was the old way. Just one metric.
Yes. For a long time, we just focused on the GFR, the filtration rate.
Right.
But they realized that one number doesn't tell the whole story. It's like judging a car's health just by its top speed.
Right. It could have a great top speed, but the brakes are shot and the wheels are falling off.
Precisely. So they use the CGA system to paint a full picture. C stands for cause, G stands for GFR, and A stands for albuminuria.
Let's break those down. Cause seems straightforward. Is it diabetes? Is it high blood pressure? What started the fire?
It seems straightforward, but it is vital, because treating lupus nephritis is very different from treating diabetic kidney disease. You have to know the enemy. If you just treat the symptoms of kidney failure without addressing the underlying cause, you are just bailing water out of a sinking boat without plugging the hole.
Right. Makes sense. Then we have G. This is the big number, the GFR, the one everyone talks about.
GFR stands for glomerular filtration rate. Think of it as the speedometer of kidney function. It measures how many milliliters of blood your kidneys can scrub clean in 1 minute.
In a healthy young adult, what are we looking at? What's a good number?
Usually over 90. So 90 milliliters a minute or more, that puts you in stage G1.
Wait, I saw that in the text and it confused me. Stage G1 is defined as normal or high. How can you have stage 1 kidney disease if your number is normal? That sounds like a contradiction.
It does, doesn't it? But this goes right back to the protein. You can have a GFR of 100 super efficient filtering, but if you are leaking albumin, if that vault door is broken, you are in stage 1 CKD.
Wow.
You have the disease, even with normal function. You have the cracked wall in the factory, even if production is hitting its targets for the day.
That is slippery. It means you can't just rely on that GFR number to say, I'm healthy.
Yeah.
You have to look at the whole picture.
Correct. You have to look at the A as well. So after G1, you slide down the scale. G2 is mildly decreased. That's a GFR between 60 and 89. Now, here is where it gets really insidious. You can be in stage 1 or 2, meaning your speedometer is still reading relatively high and still feel perfectly fine, even though you have CKD.
This is that silent zone we talked about.
This is the silent zone. Then we hit stage G3, which is 30 to 59. This is where most people get diagnosed because this is where things start to show up. G3 is essentially the middle ground. This is usually where we start seeing the first real signs of trouble in the blood work. Anemia might start to appear. Bone issues might be brewing under the surface.
And after G3, it gets serious. G4.
G4 is severely decreased, a GFR of 15 to 29. At this point, you are preparing for the worst. You're having conversations about dialysis and transplant. And finally, G5, which is kidney failure, defined as a GFR of less than 15.
The text made a specific point about terminology here that I thought was interesting. It used to be called end-stage renal disease, or ESRD, but they're trying to shift that language. Why is that?
Yes, and the distinction is important for clarity with patients. Stage 5 is kidney failure. The term ESRD is now specifically reserved for patients who are actually on dialysis, what they call renal replacement therapy, or have had a transplant.
So you can be in kidney failure but not yet be end stage.
You can. You can be in kidney failure stage G5 with a GFR of 10 but not yet be on dialysis. You are walking around living your life, albeit very, very precariously. The term ESRD now implies treatment has begun.
Got it. So that's the G. Then there's the A for albuminuria. Why add this separate category? If we used it to diagnose the disease in the first place, why is it also part of the staging?
Because the amount of leakage predicts the future. It's not just a yes or no question. The A category grades the leakiness. A1 is normal to mild, A2 is moderate, and A3 is severe. Think of A as the slope of the decline.
Slope? What do you mean?
Yes. You can have two people with the exact same GFR, say 50, they're both stage G3, but the one who has A3 albuminuria, meaning massive protein leaking, is on a very steep slope. They are sliding toward failure much, much faster than the person with A1 albuminuria.
So the protein leak tells us how fast the train is moving toward the cliff.
Exactly. It's a prognostic marker. It's our crystal ball. High albuminuria is a sign of high pressure and active damage inside the kidney. It tells us we need to be much more aggressive with treatment.
And predicting the future is key here because, as we said at the start, the clinical presentation is insidious. The text describes this silent zone in detail.
It is the most dangerous aspect of the disease. Patients in stages 1 and 2, and often even early stage 3, usually have absolutely no symptoms. None. No pain, no trouble peeing, they feel fine, they go to work, they play with their kids. This is why screening, especially in high-risk populations like people with diabetes or high blood pressure, is so vital. If you wait until you feel sick, you are often already in stage 4 or 5. The game is almost over.
And when you hit that wall, the uremic crash, let's call it, the text lists the symptoms that appear in stage 5, and it sounds miserable. It sounds like your whole body is just poisoned.
It is. It's systemic toxicity. The kidneys aren't clearing waste, so that waste builds up in the blood. We call this uremia. And the symptoms are broad, as you'd expect. Crushing fatigue, profound weakness, mental confusion, or fogginess.
Like you can't think straight.
Can't think straight at all. Nausea, vomiting, loss of appetite. But then you get the specific ones mentioned in the source that really paint a picture of how broken the metabolism is.
Like cold intolerance. That one stuck out to me.
Exactly. Patients are freezing in the middle of summer. They're wearing sweaters when it's 80 degrees out. Their metabolic thermostat is broken. Their body can't generate heat efficiently.
And peripheral neuropathies. That sounds ominous.
It's nerve damage. The uremic toxins in the blood literally start to poison the nerve endings. You get numbness, tingling, or burning sensations, usually starting in the feet and moving up the legs. We call it a stocking glove distribution.
And the itching. I've heard about that. The text calls it pruritus. It's supposed to be deep, right? Not like a mosquito bite you could just scratch.
It is often described as being under the skin. It's caused by the buildup of phosphorus and other toxins depositing in the tissues. It can be maddening. Truly maddening. Patients will scratch until they bleed because they just can't reach the itch.
And it's so important to remember this. By the time you were feeling cold and itchy and numb, you were likely nearing the need for dialysis. The body had completely exhausted its ability to compensate. The silence is over, and now it's screaming.
The alarm is finally going off, but the fire has already consumed most of the house.
So we have this silent progression leading to a crash. I want to understand why it progresses. Why can't the body just stop the damage where it is? The text broke down the risk factors into 3 baskets: susceptibility, initiation, and progression. I found this really helpful to organize my thinking.
It is a great framework. Think of it like a forest fire. The first basket is susceptibility factors. These are the conditions of the forest, the dryness of the wood, the lack of rain. They don't start the fire, but they make the forest vulnerable.
And these are mostly things we can't change, right? The hand you're dealt.
Largely, yes. Advanced age kidneys age just like skin does. They lose mass, they scar over time. Then there's reduced kidney mass. Maybe you were born with only one kidney, or you had a very low birth weight, which implies you were born with fewer nephrons to begin with.
Fewer workers in the factory from day one.
Exactly. Racial or ethnic minority status is listed as a susceptibility factor, which is often tied to genetic predispositions like the APOL1 gene variants that are more common in individuals of West African descent, and of course, a family history of kidney disease. These things set the stage.
Then comes the second basket, initiation factors. These are the match strikers, the lightning bolt.
Correct. These are the agents that directly damage the kidney. And the big two, which we will discuss at length when we get to treatment, are diabetes mellitus and hypertension.
High blood sugar and high blood pressure.
They account for the vast majority of CKD cases. But this basket also includes autoimmune diseases where the body attacked its own kidneys, like glomerulonephritis, or structural issues like polycystic kidney disease, where cysts grow and crowd out the healthy tissue.
And the crucial part here is that many of these are modifiable.
Yes, this is where we can intervene. You can treat diabetes, you can treat high blood pressure, you can prevent the fire from starting.
And then the third basket, progression factors. These are the things that, once the fire started, act like wind and pour gasoline on it.
Exactly. These hasten the decline. If you already have kidney damage from diabetes and then you smoke, or you have uncontrolled high blood sugar, or you are obese, the kidney fails much faster. But the most critical progression factor, and the text emphasizes this repeatedly, is proteinuria.
We're back to protein again. So I thought protein was just a sign of the damage. You're saying it actually causes more damage.
This is a critical insight and a bit of a mind bender. Protein is directly toxic to the kidney tubules. Remember, the filter leaks it out, but then the tubules downstream, the pipes, they try to be helpful. They try to reabsorb it to save it.
They're trying to put the gold bricks back in the vault.
They are, but the process of grabbing all that extra protein causes inflammation and scarring in the pipes themselves. So the leak isn't just a sign of the hole. The leak actively makes the hole bigger. It is a vicious, self-perpetuating cycle.
That phrase, vicious cycle, seems to be the theme of the pathophysiology section. The text describes something called a final comment pathway. It seems like no matter what starts the damage, diabetes, blood pressure, whatever, the kidney ends up destroying itself in the exact same way.
This is the core mechanic of CKD. This is the engine of the disease. To understand it, we have to go back to that factory analogy. Imagine your kidney is a factory with 1 million tiny workers. These workers are the nephrons.
Okay, 1 million workers.
A disease comes in, say uncontrolled diabetes, and it's a terrible manager. It fires half them. You're down to 500,000 workers left. But the factory quota hasn't changed. The body still produces the same amount of waste that needs filtering every single day. So what do the remaining 500,000 workers do?
They have to work twice as hard. They're pulling double shifts.
They do. In the kidney, the surviving nephrons undergo what we call hypertrophy. They physically get bigger. And they undergo hyperfiltration. They crank up the pressure inside their own filtration units to force more blood through faster. This internal high pressure is called glomerular capillary hypertension.
So it's like the factory manager is screaming at the remaining workers to run the assembly line at 200% capacity.
Exactly. And in the short term, it works. The GFR, the overall factory output, stays stable. The patient feels fine. The blood looks clean on the lab report. But what happens when you run delicate machinery at 200% capacity, 247, for years on end?
It burns out. It breaks down.
It explodes. The high pressure physically damages the delicate filters, causing scarring. We call it sclerosis. So another 100,000 of those survivors die from overwork. Now you have 400,000 workers doing the job of 1 million.
So they have to work even harder.
Even harder still. So they die faster. Then you have 300,000. Then 100,000. It's an accelerating death spiral.
It's a suicide pact. The very mechanism that saves you in the short term, working harder, is exactly what kills the organ in the long term.
That is the fundamental tragedy of chronic kidney disease. Once a critical amount of nephron mass is lost, the kidney is programmed to destroy itself unless we intervene. We have to step in and tell the workers to slow down. We have to lower the quota.
Which brings us to Section 3, stopping the train.
Yeah.
Treatment and management. The primary goal here, as the text states so clearly, is to delay progression. We want to keep the patient in stage 3 for as long as humanly possible.
We want to buy time, We want to flatten that curve of decline. We want to prevent that slide into stage 5 where life-altering therapies like dialysis become necessary.
And it starts with lifestyle, the non-drug strategies. The text wasn't vague here. It gave very specific numbers. Let's talk about diet first. This is where the rubber meets the road for patients.
It absolutely is. And the cornerstone is protein restriction. This connects directly back to that overworked factory analogy we just discussed.
How so?
Protein metabolism creates nitrogenous waste, urea, ammonia, creatinine. These are the main products the kidney factory has to filter and remove. The more protein you eat, the heavier the workload on those few remaining nephrons.
So lowering protein intake is like lowering the production quota for the factory.
Precisely. The source recommends restricting protein to 0.8 grams per kilogram of body weight per day if the GFR is less than 30. This directly reduces hyperfiltration, it takes the pressure off, it allows those dangerous speeding workers to slow down to a sustainable pace.
Let's do the math on that for a second. For a 70-kilogram person, that's about 154 pounds, 0.8 grams per kilo, is roughly 56 grams of protein. That is not a lot.
It isn't. An average chicken breast has maybe 30 grams, a container of Greek yogurt has 15, a couple of eggs have 12. If you eat that, you're basically done for the day.
That is a massive, massive shift for the average Western diet, which is usually double or even triple that amount.
It is a huge adjustment, and it requires a dietitian. It's not something you can just guess at, but it is one of the most effective non-pharmacologic tools we have. Alongside that, the text prescribes exercise, a specific prescription of 30 minutes 5 times a week.
And what does exercise do?
It helps with blood pressure control, weight control, insulin sensitivity, all things that protect the kidney. And speaking of weight, the target is a BMI of 20 to 25. And of course, the big one, smoking cessation.
The text was pretty blunt about smoking. It's not a suggestion.
It is non-negotiable. Smoking is a potent vasoconstrictor. It tightens blood vessels. The kidney is basically a tightly packed ball of blood vessels. Smoking with CKD is like trying to force water through a pinched hose. It starves the organ of oxygen and accelerates the decline drastically, particularly the cardiovascular risks that come with CKD.
Okay, so lifestyle is the foundation. Diet, exercise, no smoking. But let's talk drugs. The text highlights the big 2 causes that we need to manage aggressively: diabetes and hypertension. Let's start with diabetes.
Controlling blood sugar is basically damage control. High sugar or hyperglycemia acts like a toxin to the kidney's filter. It literally gums up the works over years. But treating it in CKD is tricky because the kidneys are responsible for clearing many of these drugs out of the body. If the kidneys aren't working, the drugs can build up to toxic levels.
Right, I saw the specific warning about metformin. Metformin is like the aspirin of diabetes. Almost everyone with type 2 diabetes takes it. But the text has some very strict rules.
It does, and for good reason. Metformin is cleared almost entirely by the kidneys. If it accumulates, it can cause a rare but often fatal metabolic condition called lactic acidosis. So the guidelines are very clear. If your GFR is above 45, continue as normal. If it drops into the 30 to 44 range, you need to review the dose, usually cut it in half and monitor very closely.
But if GFR drops below 30?
Just continue. Stop immediately. It becomes too dangerous. The risk outweighs the benefit. And this is why patients need constant monitoring. A drug that was perfectly safe for you last year might be toxic this year because your GFR dropped from 35 to 29.
That's a huge takeaway. Just because you've always taken a medication doesn't mean it's still safe as your kidneys change. Now, let's move to blood pressure. This section felt like a numbers game in the text.
It is a numbers game. And it's critical because hypertension is both a cause and a consequence of CKD. It's another one of those vicious cycles. The text gives us 2 specific targets. The standard target is less than or equal to 140/90. This applies if your urine albumin is low, so less than 30 milligrams per day.
But if you're leaking protein, the rules change.
Then the rules tighten significantly. If your albuminuria is greater than 30 milligrams per day, the target drops to 130/80.
Why the stricter target?
Because that protein leak, that A2 or A3 status, tells us that the pressure inside the kidney in those tiny filters is dangerously high. We need to lower the systemic blood pressure even more aggressively to protect the filter from blowing out.
And the weapon of choice here. The text was very specific about the type of blood pressure medication to use. It wasn't just any old pill.
No, absolutely not. The first-line drugs are ACE inhibitors, or ARBs. These are drugs that usually end in pril, like lisinopril, or sartan, like losartan.
Why these specifically? What makes them so special for the kidney?
This is a crucial nuance of renal physiology. Most blood pressure pills lower pressure in the whole body by relaxing the arteries everywhere. ACE inhibitors and ARBs do that, but they also do something very special. They preferentially dilate the efferent arteriole.
The efferent arteriole, that's the exit door of the filter. Right.
Exactly. Think of the nephron filter, the glomerulus, like a garden hose with a nozzle. Blood comes in the afferent arteriole, the entrance, and goes out the efferent arteriole, the exit. To get high pressure in the hose, to spray water really hard, you pinch the exit nozzle. That's what the kidney does to hyperfilter. It pinches the exit to raise pressure inside.
So the kidney is naturally pinching its own hose
Yeah.
to keep the pressure up and maintain function.
Yes. It's part of that maladaptive compensation we talked about. And what ACE inhibitors do is they specifically unpinch that exit. They dilate the efferent arteriole. They open the nozzle.
So the blood flows through easier, but with less damaging pressure.
Exactly. It relieves that factory worker stress we talked about. It takes the burden off the remaining workers. However, there is a catch, and the text mentions this very clearly. Because you are lowering the pressure in the filter, you will actually see the filtration speed drop.
Wait, so the GFR, the number we use to measure kidney health, gets worse when you start the drug?
Temporarily, yes, it's expected. You start the drug, and 2 weeks later, your GFR might drop 10 or 15 points. Your creatinine will go up.
Oh, that must freak patients out. Doctor, you gave me this pill to save my kidneys, and now my number is worse.
It happens all the time. And it's our job to explain that this is a benign drop. You are trading an artificially high damaging performance for a lower, safer, sustainable pace. It's like telling the sprinter who is about to have a heart attack to slow down to a jog so they can actually finish the race.
That is fascinating. So you have to accept a slightly worse number today to save the organ for tomorrow.
Yes. The text advises starting with a low dose and titrating up slowly. We have to monitor potassium levels closely, as these drugs can cause potassium to spike, which can be dangerous. But as long as the drop in GFR is less than about 30% from baseline, we tolerate it. In fact, we welcome it. It means the drug is working.
Okay, so we've handled the pressure and the sugar. We've stabilized the factory. Now let's move to the complications. Because as the kidneys fail, they stop doing their other important jobs. And one of the biggest jobs is building blood.
Anemia. This is section 4 of our deep dive, the anemia of CKD. Most people don't associate kidneys with red blood cells, but the kidneys are the primary producers of a hormone called erythropoietin, or EPO.
EPO, that's the stuff cyclists use to cheat in the Tour de France, right?
The very same. But in the body, it's the text message that the kidney sends to the bone marrow. The message says, hey, oxygen levels seem a bit low. Time to ramp up production of red blood cells. When kidney tissue turns to scar tissue, it stops making EPO. The Wi-Fi goes down. No text message is sent. The bone marrow just sits there, idle, waiting for instructions that never come.
So you become anemic. The text defines this as a hemoglobin level less than 13 for men and less than 12 for women. But the treatment strategy here had a very specific order of operations. You can't just jump in and give the patient EPO injections.
Correct. And this is a common pitfall in management. The expert insight here is iron first. Think of EPO as the foreman yelling at the construction crew to build a brick wall. But if there are no bricks in the yard, all the yelling in the world doesn't help. Iron is the brick.
And the text says iron deficiency is the #1 reason that anemia treatment fails in these patients.
Yes, absolutely. CKD creates a chronic state of inflammation where iron is poorly absorbed from the gut and poorly utilized by the body. So before you even think about giving the expensive EPO drugs, you must load the patient with iron. And the source explicitly favors 5E iron, so intravenous, over oral iron pills.
Why is that? I mean, I'd much rather take a pill than get an IV infusion. It seems so much easier.
It seems easier, but it's about effectiveness and side effects. Oral iron is very poorly absorbed in CKD patients because of high levels of a molecule called hepcidin, which blocks iron absorption from the gut. Plus, oral iron causes terrible gastrointestinal issues, nausea, constipation, cramping, dark stools. It's miserable, and patient compliance is very low.
So they just stop taking it.
They stop taking it. 5 iron, on the other hand, bypasses the gut completely. It gets the bricks right to the bone marrow where they're needed. And crucially, the text points out that giving adequate IV iron reduces the amount of EPO medication needed later on, which saves money and reduces exposure to potential side effects of those drugs.
Okay, so we fill the warehouse with iron bricks first. Then we bring in the foreman, the ESAs, which stands for erythropoietic stimulating agents. Drugs like epoetin alpha or the longer-acting darbepoetin alpha.
Right. These are the synthetic hormones that replace the missing EPO. But there is a huge safety warning here, a major point of controversy for years. You do not want to bring the hemoglobin back to normal levels.
That seemed completely counterintuitive to me when I read it. If normal hemoglobin is 13 or 14, why does the check say the target is only around 10 or 11? Why not fix it all the way?
Because multiple large clinical trials showed that pushing the hemoglobin too high with these artificial drugs actually caused harm. It increased the risk of stroke, heart attack, and hypertension. The theory is that the blood becomes too thick, too viscous for a damaged cardiovascular system to push around effectively. It basically turns to sludge.
Yikes. So you're trying to help, but you end up causing a stroke.
Exactly. So the goal isn't normalcy. The goal is symptom relief and avoiding the need for blood transfusions. It's a delicate balancing act. We want enough red blood cells to give you energy and improve your quality of life, but not so many that we clot your arteries.
Balance seems to be the theme here, which brings us to arguably the most complex system the kidneys regulate, the bones. This section blew my mind. The text calls it the bone-kidney axis.
This is the real aha moment for many learners when they study CKD. We call it CKD MBD, chronic kidney disease, mineral, and bone disorder. It explains how a disease in an organ in your back can cause you to suffer a bone fracture just from stepping off a curb.
Let's trace the mechanism, because it's a beautiful, terrible domino effect. It starts with vitamin D, right?
Yes, most people don't know this, but the kidney is responsible for the final critical activation step of vitamin D. You can eat all the vitamin D fortified cereal you want or sit in the sun for hours, but the kidney has to perform the last chemical step to turn the key and make it active.
So when the kidney fails...
When the kidney fails, vitamin D activation stops. The key is never turned.
And without active vitamin D, the gut can't absorb calcium from your food.
Exactly. It just passes right through you. So your blood calcium levels start to drop. Now, the body absolutely hates low calcium. The heart needs a stable calcium level to beat properly. The nerves need it to fire. The body will prioritize blood calcium over everything else.
So the body's internal monitoring system kicks into high gear.
The parathyroid glands in the neck, they are tiny, but they are powerful. They are the body's calcium thermostats. They detect the drop in calcium and they panic. They start pumping out parathyroid hormone, or PTH.
And what does PTH do?
It goes to the bank to make a withdrawal, and the only calcium bank in the body is your skeleton. PTH commands the bones to release their calcium into the blood to keep the heart beating and the nerves firing.
So the body is literally dissolving its own skeleton to maintain a normal blood calcium level.
Yes. This is called secondary hyperparathyroidism. The result is a condition called renal osteodystrophy, weak, brittle, painful bones. But it gets worse.
How does it get worse than dissolving your own bones?
Because the chemistry gets completely chaotic. At the same time this is happening, the damaged kidney can't get rid of phosphorus from the diet. So you have high phosphorus in the blood, and now you have high calcium being pulled from the bones. When high levels of calcium and phosphorus meet in the blood, they bind together. They precipitate out of solution.
They turn into solid matter.
They turn into a rock-like substance, calcium phosphate. But it doesn't deposit in the bones. It deposits in the soft tissues, in the blood vessels, in the heart valves. You get what's called vascular calcification. Your arteries, which should be flexible tubes, literally turn into rigid pipes.
So your bones get soft and your arteries get hard. That is an absolute nightmare scenario.
It is. This is why cardiovascular disease is the #1 killer of kidney patients by a huge margin. Their blood vessels lose all elasticity. Their risk of heart attack and stroke skyrockets.
So managing this requires what I called in my notes the alphabet soup of medications. We have to attack every single step of that chain reaction.
We do. First, we tackle the high phosphorus. We use drugs called phosphate binders. These are pills that a patient has to take with meals every single time they eat. They act like a sponge in the stomach and intestines. They grab the phosphorus from the food and carry it out in the stool so it never gets absorbed into the bloodstream in the first place.
The text listed a few different types. Something as simple as Tums.
Calcium-based binders like calcium carbonate, which is Tums, or calcium acetate, which is a drug called Physlo. These are effective and they're cheap, but you see the problem. You are adding a huge load of calcium to a patient whose arteries might already be calcifying. So the text warns to limit the total elemental calcium from binders and diet to 2,000 milligrams per day.
So if you can't use calcium or you need to limit it, what do you use?
Then you move to the non-calcium-based binders. The text mentions two main ones, sevelamer and lanthanum. Sevelamer is very popular because it works like a resin sponge, it doesn't contain calcium, and it has a nice side effect of also lowering cholesterol, but they are much more expensive than Tums.
And there was a big warning in the text. Avoid aluminum and magnesium binders.
Yes. A historical note, in the past we used aluminum-based binders. They work great for phosphorus, but we found out the aluminum accumulated in the brain and bones, causing a devastating syndrome of dementia and bone disease. They are largely obsolete for chronic use now.
Okay, so we've blocked the phosphate from getting in, but we still have the vitamin D problem and the screaming parathyroid gland.
So we have to replace the vitamin D. We give active vitamin D, a drug called calcitriol, or newer analogs that the text mentions, like paracalcitol and oxycalciferol. These drugs go to the parathyroid gland and essentially say, hey, it's okay, we have enough vitamin D, you can calm down now, stop screaming at the bones.
And finally, there was this third class of drugs that seemed really clever, calcimimetics, like cinacalcet.
This is a very clever drug. It acts as a mimic, as the name implies. It binds to a receptor on the parathyroid gland and tricks it into thinking that calcium levels in the blood are high, even when they're not. So the gland just shuts off PTH production. It breaks the cycle without having to flood the body with more calcium or vitamin D.
It's amazing how much complex chemistry and pharmacology we have to deploy just to do the jobs that kidneys were doing silently, for free, every second of every day.
It really highlights the incredible burden of the disease. And remember, the patient has to manage all of this. Taking 5 phosphate binders with every single meal and snack, taking their vitamin D at night, getting their iron infusions once a month, checking their blood pressure twice a day. It is a full-time job.
Before we wrap up the treatment section, there was a quick but important mention of lipids cholesterol.
A simple but firm guideline here. Statins, like atorvastatin or rosuvastatin, are recommended for most adults 50 and older with CKD, regardless of their cholesterol levels. Because the risk of death in CKD is so overwhelmingly cardiovascular, managing lipids is considered non-negotiable primary prevention.
So, Section 6, the integrated view. If I'm a patient with advanced CKD, I'm living by a strict, complicated schedule.
You are. Managing CKD is not a passive process. It requires high health literacy, constant vigilance, and a huge amount of personal effort. You are the project manager of your own body in a way that most healthy people can't even imagine.
Which brings us to the end of our deep dive.
Yeah.
We've covered a lot of ground. We went from that subtle 3-month definition to the overworked nephrons, to the dissolving bones and hardening arteries. What is the big overarching takeaway here?
I think the main takeaway is that the complexity of CKD proves that it is a truly systemic disease. It starts in the kidneys, but it ends up being a disease of the heart, the blood, and the skeleton. You cannot compartmentalize it. You cannot treat the kidney in isolation from the rest of the body. Everything is connected.
And for the listener, for someone out there who feels fine, why should they care about all this?
Because knowledge is prevention. We talked about those 3 baskets: susceptibility, initiation, and progression. If you know that high blood pressure initiates the damage, then treating your blood pressure today isn't just about your heart. It's about saving your kidneys 10 years from now. Those routine urine tests that your doctor does at your annual physical, the ones we barely glance at, they're looking for that microalbuminuria. That is the smoke signal, years before the forest fire starts. Don't ignore it.
That really resonates. It's all about catching it in that silent window when you still have a chance to change the outcome. I want to leave everyone with a final thought to mull over. We spent this whole hour talking about how amazing the body is at compensating, how the remaining nephrons work harder, how the parathyroid gland tries to fix the calcium levels. This adaptability is what keeps us alive from one day to the next. But in the case of CKD, that very same adaptability is exactly what masks the problem. It hides the struggle until the damage is almost irreversible, and it forces us to ask a really fundamental question. How much do we rely on feeling okay as a measure of our health when our own biology is designed to lie to us to mask the struggle until the very end? Maybe feeling fine isn't enough proof that we are fine.
A sobering, but a very necessary question.
That's it for this deep dive into the silent system. Thanks for listening.
Stay curious and stay healthy.